Good evening, everybody, and a really, really warm welcome to episode 4 of our Fireside series of CPD for Clinicians. This year, as you know, my name is Andy. I work for Portman Dental in the talent team. Absolutely thrilled this evening to be joined by Dr Simon Norton from our dental surgery monster of a practice in central London, one of the newest acquisitions that Portman Dental have made. 15 surgeries in that practice, and Simon's been there for over 20 years. He's got a background in general dental practitioner type things, and a very strong background in oral surgery as well. So this particular session is on practical applications and approaches to ridge preservation, a follow-on from last week's session with Susie and Gillian. As always, CPD is awarded. We do know who you are, we know your email addresses. CPD is not a quick process in Portman because it's a manual one, but rest assured, we know who you are. We know you'll due certificates really, really soon, so please don't worry about that. There's a couple of videos to show you a little bit later on, and some QR codes, which Simon's going to explain to you as well. But in the meantime, Simon, great for you to join us this evening, and over to you, sir.
Brilliant. Okay, thanks, Andy, and thank you so much for the invite to give a webinar this evening. This really is a follow-on from the fantastic last webinar on effectively the practical applications of taking teeth out. This really is almost an extension or sits parallel with that. You will see on here that there are a few QR codes, as Andy says, that I've just sort of dotted around this short presentation this evening. It's really designed to try and say, what else can we do when we take teeth out if we're thinking about planning other restorative dentistry along the way? And quite often people talk about ridge preservation, and this is really a sort of walkthrough on that subject. The first QR code, if you're a little bit nerdy, I'm just beginning to get more nerdy as I get older. And if you would just take your phone and hold up at the QR code, that will take you to my email. You are very welcome to fire questions off at me for me to answer during the course of the week, if that would be helpful for you. And where I've used any references, I'm not sure that a Wednesday night really is the time to be sort of scribbling down references and working out what's what. And I've kept most of the references that I will talk about tonight to be really very short and just the abstracts, because I think that does help sort of point us in the direction of just how to change our learning and say, you know, what are we going to change about what we do, if there's anything we change, having watched this evening. So what's coming up? Well, there's me talking a bit. I work, as Andy said, I'm really excited to be part of Portman. I am 8 months in, and our integration process is over, and very much I feel part of Portman. So with that, I'm going to be talking now about what happens this evening. There's a bit of what and there's a bit of why do ridge preservation. And I think if you're going to actually understand some of those processes, we've got to take ourselves back to a few steps that for me is a rather embarrassing, 40 almost years, when I started learning my physiology of the mouth and the body. And at the same sort of time, we're going to talk about bone anatomy, going to talk a little bit of an anatomy in the jaw, which I hope isn't a sort of a yawn moment, but really is one of those, to understand something, you've really got to understand almost the grassroots. And one of the big grassroots of our question here is we're going to talk about stuff called bundle bone. Some of you will know what it is, and for some people it might be a new term. Every day, particularly when we take teeth out, we come across healing, and a big part of ridge preservation is going to be talking about modifying healing to make it work to our advantage. And I think the only way to do that easily and possibly is to have a practical demonstration. So there are two very slightly different techniques that I would like to run through, which we put together some video with a little bit of help from myself, a little bit of help from Geistlich, and I think there are 15 people who have got some kits that Geistlich have sent out to you. If you're not one of those people, absolutely don't worry or don't panic that just watching the video is a very good way of being able to start to get that knowledge. And at the very end of the presentation, one of the little QR codes to click on is something so that you can get a little bit more information. And I'm absolutely sure that the chaps at Geistlich will be really happy to let you have a look and use some of their models as well to start, or to talk about where we can get some more in detailed training on it. Well, I think to use Gillian's term last week with a slight snigger that she put in there, which I thought was very funny, Gillian, about wet-fingered dentists. Well, we're going to talk about cases that I come across all day, every day, and this chap is exactly the sort of person that we will see who presents to us with a tooth that needs to come out. We really need to start thinking about trying to keep volume. I'm going to make reference a couple of times to the rather strange times in which we live and which we work. The sort of, I don't know if we're post-COVID, are we peri-COVID, are we, I don't know where we are, but I'm sure that so many of us have got patients who suddenly have become a little bit more demanding. And I think that one of the things we need to be doing is bringing in the questions of what are we going to do after the tooth comes out, rather than just talk about taking the tooth out and seeing what happens. Because the big thing that we really, really want to do is to try and stop the collapse that happens when we take teeth out. In a nutshell, what is it? Well, I'm going to talk really about putting something into the socket to help. I'm going to limit what we talk about what to use this evening, partly because our kind sponsors of Geistlich will steer us in one direction. And we're going to talk about the use of BioWAS collagen and a couple of membranes that can go with that. Historically, and if we were in the US, there would still be greater talk about using demineralized freeze-dried human bone. And because of the fact that we live in a world where we should, and I think it's right to ask questions about whether we should use animal products or not, there are synthetic variants of the materials that I'm going to talk about today that we can use. If we look at the evidence and we look at the data, using cow-derived bone, it still sits really as the very gold standard of the materials that are available to us. We touched as well on extraction technique last week. What still surprises me a little bit, that at some dental schools, there is still techniques that are taught that don't necessarily preserve bone. It's a question of just being able to take a tooth out. It's still not all dental schools talk about the use of luxators. I think sharp luxators is something that probably has changed most of our lives. And if Gillian and Suze's presentation the other week didn't stimulate you to get the catalogue open and start looking for some luxators, I would say they really are a life changer for us. But it's the use of them, it's the careful use of them, and using rotational forces then, dividing up teeth into their separate roots if required, mean that we can try and preserve the buccal wall as much as possible. And there's one thing that we really need to do. We really want to try and limit the collapse of bone around there. We then take that on perhaps further than we might do if we're going to put something into the socket, and we will spend a little bit more time debriding the socket rather than taking the tooth out and just waiting for a clot to happen. The videos talk about the use of putting in some cow bone into it, and then how are we going to guide the epithelial tissue to grow over the top of it in a reliable fashion. So the first clinical or practical slide really of use is to look at taking out an upper premolar. This is exactly the sort of scenario that I think all of us see, and in some ways some of us might dread, thinking, oh my goodness, I know that that's going to be a difficult tooth to take out, and if we're going to put an implant in there at a later stage, how is it going to look? So with that, one of the practical things, I'm going to talk about it more with the videos, but if we want to guide how the tissue grows over the top of that, it's a really good idea to be able to de-epithelialize the periphery of the socket entrance, and you can use a scalpel for that. I use a slow running diamond around the periphery of it. We're going to talk about putting that material into the socket, how we put it in. It's a question of being able to encourage bone into the site, bearing in mind that none of the products that we have available to us at the moment are in any way osseo-inductive. They are purely osseo-conductive, so they draw in cells from outside. And we want to make sure as well that the faster growing gum tissue doesn't grow down into the inside of the socket. So we're going to guide the epithelial tissue. So when we come back to look at a socket such as this a week or 10 days later, one of the things that you'll see is straight away a white epithelium growing right over the top of it, and you don't get that characteristic collapse or invagination of the socket. So we start to be in control of what we do really right from the beginning. And then ultimately, this is a slide taken 4 months later. Isn't that just the most perfect site, even if we weren't going to be placing an implant, to say if we were going to do an adhesive bridge in a site, that the more tissue there is, then the better chance we have of getting a good outcome. So the why. Well, I have to say I'm a little bit jaundiced about some aspects of how the world sometimes will place implants. There's a term that has been started to use a little bit more of late, that people talk about revision surgery for implants. Generally speaking, that means taking them out and doing it all over again. And I think it is something that we will increasingly see, maybe because some of the questions, or some of them even perhaps put so boldly, to say the mistakes from the past, where many of us, me included, would sometimes shoehorn an implant into the narrowest section of bone, or even have lateral cantilevers with huge forces generated on the implant. So really the why of ridge preservation is a large part, not just to make our life easier now, but to prevent problems coming later. So we really need to preserve as much volume, and that means width more than anything. But the same technique can be used if we've got a sinus. We know that we get with sinuses a pneumatization of a sinus with an upper sixth, that the roots are very close. Wouldn't it be nice if we could keep the sinus almost exactly where it is and not want to take the space that we would like to use later? So this is about keeping ridge volume. Of course, again, coming back to perhaps the post-COVID period, where people spend, probably like all of us, more time in front of Zoom than any of us would really like to. And that might even be webinars included, so I appreciate you watching. But we want good aesthetic outcomes, and I think our patients are just becoming increasingly keen on that. The greater volume of tissue that we have allows us to have tissue that we can at least play with, and what a great problem to have more tissue rather than less. It goes on to maintenance, and again, I've been lucky enough to be able to watch implants that I've placed now for 30 years in practice. And one of the keys to that is the question of maintenance. Prosthetic thoughts, prosthetic designs have changed a lot as well to make sure that we can keep implants clean. But if we don't have good keratinized or connective tissue around our implants, we stand very little chance of keeping implants for the long term. So really this is about keeping stability of both hard and soft tissue around implants. I had a really good expression the other day. We were talking about what happens when we take teeth out, and we were talking about giving patients a treatment plan. I think one of the most useful things is not just to accept, like on this short video here, what happens and then face the consequences later. I think the big thing is making a treatment plan. Of course, we have our regulations that say to us we ought to be giving a treatment plan for correctness to our patients. But I think a treatment plan is also for ourselves, to give ourselves really the roadmap that says, how are we going to end up? Looking at this healing socket here, what shape would we like our alveolus to be? Do we accept that we're going to get shrinkage, even if it's just for a bridge underneath a pontic? There are some great and some rather ugly examples of how failed implants look, because we get a loss on the outer wall of it and then all the problems of peri-implantitis. So a treatment plan, I think, for us is not just to talk about before we take the tooth out, but it's a really helpful guide to us to say, talking it out loud, we can share that with our patients a bit. So we're going to talk now about modifying with a biomaterial the clot that we've got here. So we're going to put something in there that doesn't resorb so quickly, and we can guide how the socket is going to heal. I think the journey perhaps is a slightly overused term in many of our practices. What is our patient journey? But there is a reality to it, that if we talk more with our patients, then we do stand a fighting chance of being able to give them at the end something that both of us want. So what are the practical consequences of taking teeth out for people? I think the more we talk about it with our patients, talk to our patients why we're doing it, make sure that they understand where the end point is before we actually talk about what we're going to do now. We need to start planning tooth replacement and talking about it, even if the extraction is an emergency, to give people a little bit of hope, to say that we're going to give them some teeth back. Again, I think it's because expectations have changed a lot of our patients. And with that, then they are used to the journey that we're going to take them on, of the timing of implants. I think if we simplify treatment right at the beginning, there's a really, Ronnie Young, who you just see underneath see if I can find it. Ronnie Young, who is a fabulous guy working in Zurich in their restorative and implant department, has given some really good and very practical advice about talking about what happens if we can preserve the site and we don't have collapse. The need for more complicated treatment later changes enormously. There's significant less need for doing invasive things. He's written a really good review on here in 3 years ago. It's worth just reading the abstract of that if you were just to click on that QR code for long enough to talk about what happens and detailing the amount of shrinkage that we expect to see. So he does also reference one of his own earlier papers talking about the significantly smaller need for augmentations later on. Well, let's get started. Let's start thinking about what sort of patients are we going to augment. I think in the same breath, when we say what sort of patients are we going to augment, there's a very big argument to say what sort of medical considerations. We need to treatment plan even for taking teeth out. And I know that frequently people come to us as an emergency, but commonly we're watching teeth that are going to fail. Sometimes it's absolutely the right thing to do to take teeth out and let nature take its course. But some of the time, we need to be very aware of all of the medical indications that make things a little bit more complicated. I'm not sure that there are any dentists in the country who are not acutely aware of the effects of diabetes, smoking and alcohol, the two, smoking and alcohol, potentiating each other's issues. I think something that is coming to the fore, and I think it is very much worthwhile having a conversation around this, talking about eating disorders and nutrition. People heal many years later less well if they have had eating disorders and nutrition. And I think we as healthcare professionals are in a very good and a very comfortable place, not just because we're talking the mouth and something simple and cheesy that we use our mouth to eat, but we're healthcare professionals. I think it's a good thing to talk to people about some of the ramifications of bone healing. We know that those people who talk about eating disorders and many of the women who end up later in life still with hormonal difficulties, issues. We know the effects and the hormonal effects on bone growth. So one of the things I think is probably sensible to say, we probably should avoid people who are diabetic, either of the types, smoking and alcohol, but also if we are looking at eating disorders and nutrition, we certainly need to be thoughtful. Are those the sort of people who are going to heal reliably and predictably? With socket augmentation, we do push the envelope a little bit further forward. And so I think we need to be very, very careful about those first three. We certainly need to be extremely careful with bisphosphonates and people on high doses of steroids. I would say these are the four categories that are, for me, certainly socket augmentation. We need to be a bit thoughtful about those people. Immune conditions, we know these are all the same things that people who place implants are becoming increasingly aware of, the alteration of the immune system and the effect that it has on bone healing. So I think if we're going to fulfill people's expectations, there is a time and a place to say keeping things simple is a good idea. But talking to people about their experience and giving them a little bit of your time to talk to them about the medical issue has a huge effect on people respecting the cost for the services that we provide. There are local thoughts, and these are exactly the same that we have if we were going to place an implant. Even if you're not placing an implant, I would love to steer you towards, I'm a very active member, a fellow of the ITI, and there's a fantastic tool in there. I haven't put a hyperlink to this, but it's very easy to find if you go to iti.org and do the assessment for the placement of implants. One of the first things that this steers us towards is something that's equally relevant for us when we're going to take teeth out, thinking about the biotype. If we ever think which sockets tend to shrink the most, it is always the thin biotype. Invariably, those lovely and smiley people are people who are going to show a very obvious or a very clear to see smile. And with thin biotypes, losing tissue can create some aesthetic disasters. That also means that the bony phenotype underneath tends to have very thin socket walls. I'm going to just touch on some evidence in a second or two that says about the relationship between thin phenotype bone there and how incredibly it shrinks when we take teeth out. So these are the sort of people that we want to augment their sockets, that not only makes our life much easier, but gosh, it ends up giving such a different result, whether you be doing something in the aesthetic zone, or for us to view the aesthetic zone for people's 6 front teeth. I'm sure all of us now realize that the aesthetic zone seems to spread a little bit further back. I think we've got Zoom to thank for that. I've touched just now on the health risk assessment, but again, I think it really makes a big difference for us being able to talk and modify and manage people's expectations, both about what to expect at the end of treatment, but also the costs of what we do. So if we're going to talk about how we're going to do and what we're going to do, I think we do need just to remind ourselves a little bit about the bony anatomy. Jaws are functional structures. Orthodontists talk about bone all the time being functional. They move teeth from forwards to backwards in here. But then the big thing is, it's so functional that we lose bone after extractions. I think it's easy for us to gloss over that. So to understand that, we're going to start talking about this funny stuff called bundle bone. What is bundle bone? Well, bundle bone here is that very thin bone that lines the ligament. It's effectively the interface between the alveolar bone and the ligament, and it is made of bone. Well, we all need heroes in all of our life, and I've got loads of heroes, actually, in all different parts of my life. I think in dentistry, we have got some phenomenal people in our profession at the moment. I'm a great fan of the tubules. having someone who can actually get together and reinvigorate our dental learning. But one of my greatest heroes is the periodontist Mauricio Araujo. He did a bit of groundbreaking research in 2005 with Jan Linder, and I'm going to put a little QR code for it. It's worth just a read, talking about what happens not just with extraction, but looking under the microscope to see what happens in terms of bone resorption. Where do we actually get that bone resorption? And we suddenly realize, here's the QR code, give that a quick click and it will take you to just the short view here, so that you can just read through that for a conclusion of it. But we realize that there is an area of the periodontal ligament that essentially the bone on the outer wall comes from the formation of the tooth. Now, this is the only and slightly tricky slide, I think, for us to talk about. Why would we look at a developing tooth germ on here? Well, 100%. We're going to look at a developing tooth germ on here because it helps us understand with that formation of our dental follicle, we look at that incredibly complicated interaction between the mesenchymal cells of the dental follicle right down to the root sheath that forms in that beginning part. And why is that so interesting for us? Well, because it reminds us that in the same way as we get all of those mesenchymal cells differentiating off into cementoblasts, fibroblasts, have those Sharpie fibers for fitting into the cementum. But at exactly the same time as that happens, then we're also getting those same mesenchymal cells are forming the socket wall by producing osteoblasts which lay down that. And then those two things come together. So as the tooth begins to erupt, the cells that come with that and the blood vessels that travel with that form one blood vessel that runs up, or a network really, through on the inside of the socket. So if we destroy the periodontal ligament, we're going to destroy its blood supply, because the blood supply to the inside of the periodontal ligament is also the blood supply to the local bone around there. And so that wall called bundle bone that forms effectively the inside shell of the socket is something that will lose its blood supply the moment that we take the tooth out. So tissue healing is all about that one little blood vessel. Not so relevant if we look at back teeth here, but because we get a huge amount of anastomoses coming from side to side. But take a CT scan of a tooth in place. And if we look just how thick that wall is on the outer part here, and you can see that is an extraordinarily thin wall. That one, in many ways, is thick compared to what a lot of the walls we see. So if it loses its blood supply, then it's no great surprise that suddenly, where is it going to get its nutrition from? And all that will happen will be that the local osteo cells and the macrophages will actually take away any cells that have no longer got a blood supply. So osteoclasts will eat up that labial bone if they don't have any nutrition. I think there's so many websites all over dentists, here, there, and a bit everywhere, that have this same slide, trying to make it look as though implants are very similar to teeth. And yes, biologically, there is a union of bone that forms onto it, but the blood supply on an implant is so very different to not having this blood supply up through the side of the ligament. And the reason for putting that there is to remind us that a large amount of the blood supply disappears the moment we take that tooth out. Again, it's a lot less relevant if you have got big, thick walls on the outer side. But on anteriors, God, I'm so surprised that there's any labial bone left after a little bit of resorption taking place. Again, just being a bit careful about making sure that we don't have too many QR codes dotted around or too many thoughts of having paper conclusions on here, but Vivian Chapuis did a fantastic bit of research looking at, and now this goes back 7 or 8 years ago, looking at what happens to thin biotypes or different biotypes radiographically. And if you look here, you can see there's a massive difference, that thin biotypes are not like the picture, the clinical picture here, where you've got a thick biotype and less likelihood of vertical or horizontal bone resorption. We're going to need that bone resorption later. And the very thought that it's going to disappear for us, again, it doesn't matter if it's doing implants or if it's doing some sort of prosthesis. But the research shows us that 66%, 2/3 of that bone resorption, takes place within the first 3 months of extraction. So wouldn't it be helpful if we don't lose horizontal loss, and after 12 months, 49% of anteriors of their bone loss will be lost, and vertical loss as well. So the combination of the two being even greater in thin biotypes says, wouldn't it be a good idea if we could do something to try and make sure that we don't get this bone loss happening and we don't get the shrinkage of bone taking place, losing the width, and the greater width loss happens in thin biotypes. So starting to build a little bit of a picture in our head to say it would be really helpful not to lose that tissue, especially in thin biotypes. So where are the times and the cases that we think that it's going to be helpful to start thinking about not necessarily tissue gain after extraction, but certainly not tissue loss either underneath that. So we've got to think of our anatomy and physiology working together to make sure that those really, really thin, these pictures here come from Vivian's work. Yes, there are a few, but I would say very few socket walls that are that thick. If we were to take a CT scan of them, some of those incredibly thin walls will disappear almost completely. And what it means from that is that the bone that's going to end up growing back in the socket has to grow from the palatal wall forwards. And that's why we end up with an awful lot less of that. So anteriors particularly are probably the first place and the prime place to start thinking about not getting both alveolar bone loss and with that soft tissue bone loss that goes with it. Perhaps if you wanted a bit more evidence, there's a fabulous review on here by Danielle on this, a short paper now, nearly 10 years ago, just detailing exactly how much volume loss that we get. So what are we talking about with socket treatments? We're talking about trying to take advantage of the phenomenal blood supply that we have. I think it's a fascinating fact that the head gets almost 1/3 of our body's blood supply, because we all think, well, of course our brain is going to be hungry for oxygen, but in actual fact, the brain itself only takes 15 or 20% of it. The rest on those arteries, those coming off from our external carotids that feed the maxillae. Wow, aren't we lucky we get this phenomenal blood supply? But with that, that's why we also get this incredibly great cellular activity that helps with the resorption. So we've really got to start guiding it. And it really does create these sort of quite big challenges for us here to say. We don't want to have to face going through block bone graftings, deciding whether we can use some sort of lateral augmentations afterwards to see if we can try and regain some lost tissue. Wouldn't it be nice to be able to keep the tissue that we've got? Well, if we're going to do that, let's think a little bit about those proliferative phases of what happens. Yeah. Let's get a stable clot formed, because a stable clot isn't going to resorb, and then we can have bone growing in from the outside. So let's modify our clot by putting something into it. I think a histological slide really is not such a good idea, again on Wednesday night. But if we can modify it, then we know that we can organize the collagen And by having a material such as BioOS collagen in there, the blood vessels and the new and developing blood vessels actually will follow down into that collagen block. They like the collagen pathways in there. And we get a much greater differentiation of osteocytes the moment that they can follow down the same pathway as the blood vessels do. So that very stable scaffold soon allows the osteocytes to start forming, providing we stop a little bit of ingrowth from the top. This sort of side here is an absolute sort of nightmare for people wanting to put implants in people. We know that the more traumatic our extraction is, then the more difficult it's going to be to put an implant in the right place, especially if we're thinking of a prosthetically driven one. It's almost impossible to put the center of our implant here where we want to. That's the sort of site that we really, really want to achieve to prevent us getting that secondary implant failure. I was going to just touch a little bit on the ethics of how we think and how we work through our questions of what do we do with our patients. I think really now is this great time where we do need to talk to people. I think we need not to be judgmental about what we are trying to tell people to have done, but I do think that we have to be educators for what we do. And I know that sometimes the learning process seems a slightly strange place, tinged in the background with having that slightly tricky thought of having medical legal people showing on our shoulders. But we've got to make sure we do the right thing. And if we do the right thing, some of the other conflicts that get a little bit more difficult, people complaining about different aspects of any treatment we provide, I think if we can start out the journey getting it right in the first place, then some of the conflicts that come with the more expensive dentistry disappear. And boy, aren't we lucky to then be able to enjoy actually doing what we do. So now we're going to move happily onto the part that's probably a little bit easier for us to talk about. We're going to talk about what do we do here. We've talked about those difficult teeth to take out, but we've got some treatment choices. Are we going to go for early placement? Are we going to try and preserve our ridge? Or are we going to go for immediates? Just to touch on immediates, there is some really good work, particularly by Arugio, that says we know that immediates on their own, implants do not preserve bone. If you're going to go down the route of doing immediates, then I would say to you, not only is it a little more complex than I think many of us used to think, but we need to be combining this sort of technique with immediate implant placements. But alveolar ridge preservation enormously allows us to be able to have simplified treatments. And those simplified treatments absolutely make sure that we don't get those bone losses that we talked about. I think it has a really big impact initially on cost, initially us being used to talking about some complexity. But it stops us worrying about people with difficulties of cleaning around their implants. It allows us to do the dentistry that we want to do and not run into the difficult aesthetic questions. It makes our treatment of putting implants in an awful lot easier if we don't have to suddenly start thinking about growing or making our treatment more complicated at a later stage. So that's the sort of result we're going to aim to achieve. I'm now just going to start just moving on a little bit here into saying thin and medium biotypes. I think there's almost a question we should ask ourselves to say, why are we not doing something that is so remarkably simple at the outset of our treatment in cases to make the outcome better? It significantly changes the aesthetics, and it really is a very new and a rather different option for us. So in the practical part here, we're going to just touch on the extraction technique, but we've got two sorts of models. So for everyone who's got models in front of them, if you start to take a look at them, you will see in some of them, and I'm going to show those in video form in just a second, that we have got some intact sockets and we've got some non-intact sockets. And we're going to talk about two very slightly different techniques So with that, I'm going to move on to the practical aspects of what we are going to do. And with that here, Andy very kindly said to me, would we like to have a little bit of video if we're going to do something like this? So this is the debut of my film career. I'd like to thank Portman for encouraging me into a new way and a new life in here. But as part of the Fireside webinars, I think having a practical skill is a really helpful thing to do. I certainly don't want to be saying much more about the use of luxators from that fantastic webinar last week. But what I would say is with the use, if you want to be able to take teeth out this easy, have sharp luxators. If you're not used to sharpening your luxators, then for anyone who's got a hygienist, he or she will help you sharpen them. And it's an absolute revelation to be able to have super sharp luxators. And that for me is an absolute key part of this whole question of making extractions easy and simple and not squashing in that labial plate. The instruments you need are remarkably little. That's 64 blade on a micro handle. Unbelievably useful for this, and I think for everything that we do. But if you look here, this is all the kits that you need. Simple stuff that we've probably all got in our surgical box. A perioprobe, a surprise to suddenly find that becomes a surgical instrument, but to explore sockets, phenomenally useful. I'm going to talk about using a periosteal elevator, but not in this scenario for raising flaps. If you take a flap up when you are taking teeth out, then you're going to start losing blood supply as well. So this is all about working within the sockets. So two scenarios we've got here. If you take a look at the upper central, you'll see that there's a small defect out on the labial wall of that. And then on the canine tooth, we can see an intact socket. So I'm going to just talk through, terribly easy and terribly straightforwardly, a couple of very simple things using these two products. Mucograft Seal is a modified collagen. It is a smaller version of mucograft that periodontists use. It is a lightly cross-linked collagen, and with that, what it does is it encourages, first of all, blood and then epithelial cells to rush into it. On the outer wall, this is the side that's going to be facing upwards towards the mouth, is a compact side, and on the side that you're going to have on the inside, it's got a little ridge on it. Lots of people know what BioOS is, which is demineralized, freeze-dried bone, but it has been constituted here as BioOS collagen. It has a small amount of porcine collagen in it. It's about 5% of it, but the particle size of the BioOS is just smaller, but is exactly the same stuff, and it sits and forms in a block form. So let's now just talk literally bit by bit about what we're going to do. I think one of the first things that we need to make sure is that the first one on our intact socket here, we just want to examine it, make sure that there is no debris left inside from our extraction. It's not unusual to find little bits of filling or flaked bits of crown that fall in there, and a proper debridement the moment we have taken out the tooth is a really sensible thing. I don't flush it out with anything unless I can see that there are remnants of amalgam in there. You can use that 64 blade or 15C if you prefer that to just take a very thin skim around the periphery so that you've got fresh epithelial cells looking at that. And I really like to make sure I've got everything ready to start with. We know that we are going to do this procedure as a planned procedure. So I like to make sure that we've got everything ready. If you are going to order BioOS collagen, it comes in two sizes. It comes in a block form of either 100 or 200 micrograms. And the first thing you need to do before you start taking the tooth out is to moisten it with saline. You can use regular saline. You can use bacteriostatic saline for people who do Botox type treatments. The advantage of that is that there is a little bit of long-acting anesthetic type agent in there that will help soften the block. It takes 5 or 10 minutes to soften the block, and all you need to do is to cut it. And I use a scalpel to cut it. I don't use scissors. You'll see me just touch on the question of using scissors in a second or two. If you use scissors, I tend to find that the action of the scissors squashes the block on the edges of it. What we're going to try and do is to achieve effectively a cone-shaped block, so that you can just literally make a pointed block. Most teeth have got a very typical apex. If there is more than one tooth root, if you're doing a premolar with an intact socket, then generally speaking, the 100 microgram block is more than enough to go inside there. Even for a canine, which are surprisingly long teeth, as endodontists keep reminding us on here, that one of these blocks will be enough. Remembering that it is all about thin bone, and it is probably the coronal 2/3 that is the part that we need to protect the most, and that's the part that resorbs. So if you don't go right down to the apex, it doesn't matter. Now, you want to condense it. You don't need to shove it in there or have it hugely dense, thinking that more product in there is going to be better. Remember, we want the cells to be able to grow from the outside and the walls of the socket. We want them to grow into that material. So condensing it and or packing any additional area around voids on the outside in there is the answer. But it really, I can't emphasize enough, it needs to fit in gently rather than having to put huge amounts of tissue into there. Now, the smooth surface sits on the outside. The underside, where there is a ridge, will go down against the tissue, but the compact side faces upwards. And you can just about see on the spongy side there's a little ridge to help you identify it a little bit easier. This is a material that is best started to be worked on when it's dry. It makes a massive difference. The moment it starts to absorb a lot of blood, it suddenly becomes a little harder to handle. And all we want to do is to effectively create a seal or a plug so that that epithelial tissue from the outside can grow into it. I might even put a suture into it before it goes into the mouth in order to help stabilize it. In this video here, I'm using some single interrupted sutures. Generally speaking, for me, 4 sutures, 1 at each corner, is enough. I think a common question for us to say is, where do you put the sutures? Don't go too close to the wall on here. You really want to be about 3 millimeters away from the gingival margin on here. Small sutures are better. The larger the sutures, the more you're going to interrupt the blood supply. We're using, for the sake of this video here, we're using some Proline sutures. You can use resorbable or non-resorbable. There is no good evidence that says one is better than the other for this. I do find that using resorbables is an awful lot more popular with people, and Proline or nylon sutures, if they're not going to undo, do need to be relatively long, and they do end up irritating the lips a bit. Size of suture, I think for me 5/0 probably is my ideal, and I have those on a cutting needle, a reverse cutting needle on here. And if you look at the size of that needle, you want something not too large, so that you've got an easy motion with your instruments, that with a turn of your wrist you can just literally swing it through from the inside of the socket coming outwards. Again, very easy being able to stretch sutures out over this person's palate. You can see how much easier it is than doing it. We've tried to do some filming on a patient's mouth, but it's rather difficult, and doing it on a model is easier for the purposes of technique on here. So again, reasonably short cutting of the sutures, and once you've stabilized two sides of it, then stabilizing the rest is a remarkably easy and a pretty straightforward thing to do. We can probably whiz through a little bit here, taking you then through to the end point of that with a final fourth suture going into here. So the small spaces on the side there, providing they have been de-epithelialized, you should find that even if you end up with some very small gaps, epithelium will jump a small amount, and if you can take a look on here, that is exactly the sort of scenario that you'll get. You end up with a great clot, and it is a very unusual thing for anybody to end up with any bleeding on there unless they've got bleeding disorders. So if we just move on to just the second part of here, not all sockets, and particularly upper anteriors, have got some sort of defect on here. The good folk of Geistlich, when they were putting together some of the captions for here, suggest that we can do a variant of two techniques. I would say very strongly for us, if you have got a non-intact socket like we've got on this upper central, we will still use exactly the same products. The technique and the variant is the same, but we've got a membrane on the inside because we do expect to lose the large part of that incredibly thin wall because it has almost no blood supply on here. So the BioGuide shape is exactly the same BioGuide. It's a little bit less expensive than buying a large sheet of it. Like all BioGuide, it's got rough on one side and smooth on the other. And we're going to use exactly the same and use the same technique that we've just used before on here. We're going to moisten our block, and we're going to do exactly the same by examining our socket and preparing it ready for putting something on the outer wall here to stop getting the ingress of tissue from the labial. So you can see here you've got a deficient buccal wall. Where are we going to put that membrane? Without question, for me, putting our membrane is going to be on here on the inner wall. If I just bring ourselves forward quickly enough to see here, do this dry because it's easier, because we are going to be able to support our membrane with the biomaterial that goes in here. It's very easy to use. Literally, if you pick it up, we can bend the membrane literally with a little fold on the inside. Anybody who's a cyclist, they look exactly the same as the Ass Saver mudguards that go on the back of my bike here. Literally, you bend and curve it, and you can slot it incredibly easily within the inside of here. And all of a sudden, you've turned what was a rather difficult scenario into an intact socket wall. And then the process of that ends up being very much exactly the same. We can then put into here our softened and our trimmed BioOS collagen. We can place that onto the inside here, and then it's just going to be a question of, again, gently compressing the tissue that's in there and folding neatly and carefully. And it takes a little bit of practice because once the membrane gets wet on here, it's a little bit more difficult to handle. I like to tuck it in dry because it's actually a little bit easier. Some people prefer to tuck it in when it's moist on here. But as you fold that over, that outer wall, literally, you can simply tuck it underneath the soft tissue, and then we're ready to suture and close it over. So as you can see on here, all of a sudden we have got, again, a nice and sealed labial wall so that we know we're not going to get ingress of soft tissue in here. This will be slower to heal because we are relying more on not having the labial plate and bone growing from the palatal and the lateral walls sideways into here. and then we can suture that into place. So I hope that seems helpful, and I hope that seems sensible. If I just escape from here just for a second or two and just come back to here, please feel free to give me a shout. I am the black QR code that comes straight to my email. But on the right-hand side of your screen, you'll see there's a blue QR code. That's Richard Bodymead of Geistlich. He would be really happy to supply you with any literature that you need to guide you as to a little bit further on this. Geistlich do actually give some formal courses that you can do and take this on a level further. And he would be very, very happy to take some of your calls or your emails. But that's Richard's email. Do feel free to give him a shout. And then from there, I think that's probably quite a good start or introduction to us to say, wow, haven't we touched an awful lot of things on what are we going to do? How are we going to modify and start changing our thinking? And I think for me, a webinar or a seminar is a first point just to say, shall we do something different? And I think now is probably quite a good time just to say, if there's anything simple I can answer, I'm sure Andy will steer you in the right direction for any questions. If you've got questions, ask away of Andy in the chat there. But if not, then I would say to you, please feel free to give me a shout. I love talking about this. I will talk about it forever with anyone. That is the great joy of me, of being part of the Portman family. I've already seemed to manage to get some really nice connections and a little bit of clinical questions toing and froing. And I think as we move forward into the future, and I think the concept of having webinars together where we all interact with each other and use some of the expertise that we've got within our group, it just strikes me that this must be a good way for us to learn. So, Andy, thank you very much for inviting me. And with that, if you've got anything that you'd like me to add or come out of presenter mode, then you might be able to speak.
Oh, thank you so much, Simon. You know, you've really endeared yourself to the Portman family already. That was absolutely fantastic, that presentation. Thank you so much. I have got a question from Priya. Now, Priya did ask it about 45 minutes ago, so I'm not too sure if Priya is still on the call. But she's asking, please can you give some advice, Simon, on how best to debride a socket?
Well, actually, I think it's a very simple thing to do, and you can do it with instruments that you have. I don't think you need special instruments. There's always people who are very keen to suggest you need this instrument or that instrument. I use actually very simple restorative instruments for it. I use a long shanked excavator to get right down to the apex, especially if it's for a canine. I think you want to make sure there's no granulation tissue left within there. And then I use a Mitchell's trimmer to literally rasp the sides of the socket. Sounds a bit horrible, sounds a bit scary, but I use remarkably few instruments for that. But I think it's a really, really important part of the treatment that we provide for people. So simple things, Mitchell's trimmer for the top part, and the hard to reach parts, a long shanked cons type excavator.
Great, very comprehensive. Thank you, Simon. Colin's asking about the costings and prices of this treatment for patients. What sort of advice or range like that?
With it? Well, I think for most, except for emergency extractions with people, I think you have to understand a sort of funny mixture. Suddenly you are elevating this question from being a simple extraction into a more complex procedure. And I think that's a little bit where, when I talk about the conversation with us about you need biomaterials, but you also need a little bit of expertise. So if we're going to be terribly blunt, for most extractions that I undertake, a fee that we charge in our practice for a straightforward extraction is about £220. If we're going to do this, I simply cover the cost of the materials, and the cost of the materials to you will be about £150. Now, I think there are great advantages in doing this as a procedure because the outcome that you get is so much better if you've got more tissue to play with. So I simply add that cost, and I add about £150 onto the cost of a normal extraction. It takes a tiny bit longer, but I think the trade-off is getting a better result for you. So if we're going to sort of talk on the pound, shilling and pence, probably Richard from the little QR code that we had up on the screen just before is a good person to talk to with Geishlik. But I don't think you necessarily need to see this as one of the big profit makers, because the benefit comes later in achieving a better product, and actually that in itself ends up selling yourself for it. So I add just a little bit over the cost of the raw materials.
Very candid. Thank you so much, Simon, and thanks for asking the question, Colin. Good to see you on the call this evening. Loads of positive feedback coming in tonight, Simon. What a hit you are. Simon, thank you for the lovely presentation. What happens, Hiranya is asking this, what happens if a socket is not fully debrided and then proceed to socket preserve, i.e. what are the risks if any granulation tissue is left behind?
Generally speaking, if you're going to leave granulation tissue behind, largely speaking, it is up towards the apex. The bit that you will encourage bone to grow in, and the bit that you preserve the most, is going to be the outer labial wall. So if you can get scenarios, but they are rare, where you will give people, or you need to give people antibiotics. To prevent that being a complication, so to answer in a slightly long way, I will give antibiotics if I'm going to do this, if I think that that has had relatively recent acute infection, or if I think that it's going to be difficult to be absolutely certain that cell by cell you have removed all of that granulation tissue. So I'm not sure it matters if you don't remove every single fragment, because I think on a cellular level, probably you're not going to be able to. But if you can make sure that they don't get a post-operative infection with this, then yes, preserving the labial wall is the name of the game, and managing the potential for infection by giving them antibiotics at the outset should counteract that as well, if that sort of answers the question.
Thank you so much. Thank you so much, Simon. One last one before we invite people to use the QR code instead of live questions this evening. Here we go. Great lecture, Simon. Thank you. Megan's asking, thank you, Simon. I couldn't quite see your suturing technique for the socket preservation. Is it a simple horizontal mattress suture, including or not including the mucosa graft in your suture, or just suturing the mucosa itself? Does that make sense, Simon?
Yeah, it does. So you really want, particularly with the mucosa graft, or actually with both of them, all you're aiming for is to make sure that the mucosa graft is, and it is sewn into, so with the mucosa graft seal, you go through the mucosa graft and through the mucosa. Simple interrupted, I think, is absolutely fine. That's all you need to do. But it's all you're trying to achieve is stability. So you don't want the mucosa of the socket to be moving around too much, and you certainly don't want the mucosa graft to do. So I would anchor it with 4 simple ones at each corner in there with single interrupted sutures. Or if you think that it really isn't stable and the tissue is moving around, then add in an extra couple of interrupted. And I think interrupted are probably better and easier to do.
Amazing. Thank you very much, Simon. That was awesome. Simon, don't tell anyone, but that's been my favourite of the series so far, I have to admit. Thank you very much.
Why don't I put up my QR code and also the link to Geishlik, and say thank you for them for sponsoring us this evening as we sign up. And Andy, why don't we just leave that on for a moment or two, so that people have got a chance to give that a quick snap there at the same time.
Let's leave that on for a moment or two. Absolutely. So I'm going to disappear on camera, off camera a second, and just leave those QR codes up for a couple of minutes. But before I sign off, thank you so much, Simon. Great presentation. And we've got one more before Christmas. Only one more before Christmas. That's on Wednesday, the 8th of December. That we're welcoming back Portman favourites, Dr. Ruth Brady, who is once again going to present for us on facial aesthetics in dentistry. I love Ruth's session as well. That's fantastic too. So, Simon, once again, thank you very much for this evening. I'm going to disappear now. Leave your QR codes up for a couple of minutes, and then I'll close the session. Thank you
That's
so
great.
much.
Okay, great. Cheers. Thanks, everyone.
See you. Bye-bye. Bye.